I'm Carolyn Shepard, and I'm the Medical Director at Clinica Family Health Services, and I have 15 minutes to do 15 slides about how we're using the data. So it's going to be a little quick. I guess I'll change these slides. I'm going to, just as an overview, talk to a little bit in order to squeeze it down into 15 minutes. Oh, thank you very much. What I'm going to do is just talk about how we got over the data's wrong, which is the first step of looking at data. And then I'm going to tell you about how we matched it to our ER data and got to the point where we felt pretty confident in looking at it, why we decided to look at potentially preventable events, and then we'll talk about emergency department. So we've used the data for other things, but I'm just going to focus on ER visits because that seemed to be the best thing I could do in 15 minutes. So this is, we had already started with our RCCOs, doing health risk assessments and looking for patients who were at risk. And so we think we have 5,500 patients in our RCCO, and we have done health risk assessment on over 1,600 of them. And we came up, it's a fairly complex thing, but in our ER we have a template and we are risking our patients. And we had about 24% who were high risk, medium risk, and then low risk patients. So we'll just run with that. And so we took a look at the SDAC data. So this is our dashboard for Clinica. And if you hit the next one for me, I'm going to focus on this instead. And it turned out, so we have about 24% of our high-risk patients. And we ground all these numbers up, and we got all the data off the SDAC, and we worked it, and we divided it and shuffled it and tried to figure it out. And it turned out if you add up dominant, moderate, chronic, and malignancies, we're at about 25%. And so we said, gee, you know, we've done all this work on health risking, and it's lining up. SDAC is telling us that the same rate, roughly, of our patients fall in the high-risk groups. So we're not going to fight the data, all right? So when we did that, we decided we would use the SDAC data, and we had someone who was pretty good at pulling down those reports and going to the spreadsheets. Only the problem was, next slide, we had too much data. So we got over the business of saying it's wrong, and then we got onto the business of saying we can't do this because it's just way out of control. So for Clinica and the bandwidth we have, we're a federally qualified health center, we decided instead to go to potentially preventable events. So just like Gordon was saying, that's where we've been focusing. And we've already got in place some strategies that have been operating now nearly a year around preventing admissions and readmissions. So that left us with services, which is a big batch, and HCPF is actually changing what they consider high-cost imaging, so we didn't want to focus there. So we've been focusing on ER visits, and we felt like even though it was claims data in 3 months maybe or more old, those patients who were super utilizers are probably still super utilizers today. So that's how we've focused on learning how to work the data. So I just wanted to show you the correlation. You can just look at the colors, I'll explain it. The blue colors are tier 1, our high-risk patients. And tier 2 is red, green is 3, and the folks who have no health risk assessment done yet is the purple. So these are people unknown. They belong in the other groups. We just haven't gotten there yet. And we looked at the cost. of our tiers just to double check and be sure we were doing okay. And there's just a lot of money in tier 1. So these are hundreds of thousands of dollars as compared to $24,000. So it lines up with what we know about our population already and where we're heading. So we've been using this data. So we're looking at super utilizers, and we're looking for potentially preventable costs. And we, again, said, well, we can't look at 5,500 patients. We want to look at a smaller number, so we took the number of clinics we have, and we decided we'd take 10 at each, roughly 10 at each, and we'd come up with a list of 50 patients, and we'd learn on the first 50. So kind of what Erin was saying, we'd do something we could. We looked at this group, and just as a sample, we had ER visits between 4 and 44. We had patients aged 9 to 52. We had 4 times as many women as men. We spent anywhere from $10,000 to $50,000 on them in a 12-month period. We had 10 to 40 high-cost images done on those 50 people in a high-cost period, or in a 1-year period. 8 to 100 prescriptions filled. So definitely folks who are using the system. We decided what we do with our super utilizers, just the group in general, is we take a look at these high folks. We have now been piloting how we're going to do our interventions. We started out with a meeting with the primary care provider and the case manager on the care team that addresses that patient. And it turned out all those patients were our patients, and all those patients we have seen. We own them. They're ours. If you look at the SDAC data, we actually, SDAC says we have about 5,700 patients, so there's 220 patients out there that we don't match, and we decided 96% was close enough for government work. And, you know, well, we had no data before. I had 0% or 96. So I could say I'm not going to use the SDAC data till it's 100%, or I'm going to look at the data. So we're using it. We're moving ahead with it. We draft a shared care plan, starting the first outline of it is done with the PCP and case manager. Then we have another meeting with the entire team, which then pulls in the patient's nurse on that team, and the behavioral health professional. So more people come in, look at the care plan, share what they know about the patient. We know a lot about these patients, unfortunately, or fortunately. And then we actually have a third meeting with the patient, and we ask the patient what do they need, and we fill in the rest of the care plan. So with these high-risk people, we're doing a very individualized intervention because they're individually quite impressive, and I'll show you an example here in a second. We meet with the patient, and one of the things that has come up is we have started adding long-term life end-of-life care planning for these people, because as we looked at this group and samples in this group, they definitely needed some help around that. And our plan is to continue to review these patients over quarters. Whether we should be looking at this list every month, I don't know. It'd be nice if we could fix these groups at an accelerating rate as we learn what they need and develop better partnerships in our communities. But we're not there yet. We don't have enough experience yet, Erin. I was going to show you this. Why don't you click it again? I'll just blow it up. So we based who we looked at on risk groups, and we would be interested in patients like this. The identifiers are chopped off, but this is a patient who's had $23,000 in preventable stuff. Now, 3M, Treo uses the 3M product, and when I first went to the meetings, they were like the black box, and there was a lot of harumping and about that. How come it's not transparent? Trade secrets, we don't know about trade secrets in community health centers. You know, we share everything, our worst practices with everybody. But we finally decided that actually there's such an alignment in our risk assessment with the 3M product that we're going to stop fighting the black box, and we're going to take advantage of what they tell us, and we're going to work on those patients going forward. Here's what our care review looks like, and this was just that he/she's list of data as we went through and looked at the chart and did the chart review, getting ready to do the shared care plan with the patient. So I'm just 14 ER visits in the last month is what SDAC said. We had discharge summaries on only 5. The patient came in for 8 ER follow-ups. We were aware of 11 of the ER visits. If you looked in the telephone template and everywhere else, you might see it. So we knew that some of this was going on. 11 of 14 we knew. Did the patient call? 5 times no. Twice the patient called and we sent him to the ER and he didn't go, so it could have been bigger, but they didn't follow us. So I'm thinking reverse psychology with this patient. Go to the ER, go to the ER. Next one. Next slide. And then here's the rest of this case review. So we do this case review and then do the care plan for each of these high-risk individuals. Was there a hospital visit before? Did we know about, did the patient tell us they had been to the ER? Is this part of a behavior issue where they're not talking to us? Did they have a complete health risk assessment? The highest score you can get in this patient's case would be 5. This patient was a 5. Health risk assessment. Mental health diagnosis, yes. Substance abuse, yes. Obese, we're finding a lot of these patients BMI 46. So how was the patient continuity? This is important to us. At Clinica, we try to drive continuity. Maybe this is something we can improve on. They saw their primary care provider 31 times, and 80% of the time it was their one primary care provider. So really pretty good continuity. Saw a behavioral health provider 17 times. So lots of services coming from Clinica to this patient. Still lots of ER access. And we ask the patient when we bring the patient in for the shared care plan meeting, why do they go? Can they tell us why they go? We like to think we know why, but I took that off this one. Lots of different ERs popping around, going different places. So the outcome on this patient is we did call up our partner mental health center. They were somewhat surprised, informed us the case was closed. It turned out that Colorado Access had a case manager at that mental health center, so we had an opportunity to talk with partners there, and the case now is reopened and the patient is getting services there too. I'd love to be able to say that they never went back to the ER, but I think it's too soon to talk about that. So that's one ER approach with us, is high super utilizers, and then we're just going to keep learning from that and hopefully making smarter decisions on subpopulations that we're looking as we're going along, learning where we can intervene and where maybe we can intervene. So that's our strategy around that. Yes, Carolyn? What do you think? So the question was substance abuse one of the things? Of course, it definitely, in this patient's case, definitely impacts he or she. Chronic pain, absolutely. I'll show you actually some other data. So the other thing we're looking at is visits, is work we've done with the IHIs to look at streams. So what kinds of needs drive patients to the ER? Not just looking at the high utilizers, which need a separate strategy, but what sends people to the ER. You know, we have a lot of children. Their parents pick them up at 6 o'clock from daycare. The kid's got a fever. They can't go to, go back to daycare tomorrow unless they get the fever fixed, or they slip them enough Tylenol so they're afebrile when they drop them off. Which is sometimes our recommendation. And you know, we have to look at what drives groups of patients to the ER. So we took our SDAC data and sorted it by cost of the ER, and then we looked at the streams that produced at least $10,000 worth of charges for at least one clinic site. So we have different populations. We have lots of homeless patients at one of our sites. So our populations are a little different at our sites. So if you hit the $10,000 threshold, we wanted to look at that by diagnosis and see what that stream is. So Dr. Gale, tell me what those were. Right? Asthma, substance abuse, chronic pain, substance abuse, more substance abuse. Dr. Farley. Okay, if you click it, so you got it. Asthma, coronary artery disease, COPD, diabetes, mental health, osteoarthritis, substance abuse, and alcohol. So we need, you know, big surprise. Those are streams. We didn't see a lot of cost, and this is what Gordon was saying. A lot of our patients go for dental care, but it's not a lot of cost. These are the people where the cost is. So we don't want to look just at frequency, but we want to impact the streams with the highest cost. And so, for example, when we had all those fires and it was smoky as heck everywhere we have a clinic, we called every super utilizer with asthma and every ACO patient with asthma, trying to be sure they were using their steroid inhalers, had refills, everything else. We called everybody during the smoky days because we figured that stream is revving up and they're heading to the ER, and we can probably do something by being proactive around the stream. So here's what we're doing going forward. We are going to continue to look at our super utilizers and learn how to be really smart about how we go after those high dots on that graph. We're doing ongoing team focus on these patients because this patient, for example, isn't somebody who isn't being seen. They've been seen 31 times in a year. So we're obviously seeing them a lot. We haven't effectively impacted their ER use. We're going to design system interventions around these streams that I just showed you. We're collecting SDAC readmit data, but our numbers are incredibly small. And so if you look by month, you have 2 patients here and 3 patients here and 1 patient. It's a good thing. It's incredibly small. So we're aggregating that. We're going to have to look at 6-month chunks to have enough patients in there to even look at. So readmit data we'll look at, but remember, we're already doing post-discharge home visits. We have another strategy that's more timely. And we'll go back and look at that data and see what it tells us. And then look at the SDAC PPA. My thing is, if you don't have an admit, you don't have a readmit. And we are really looking everywhere. Project Red, everything is focusing on the readmits. And I want to see if we can do something about just not having patients go to my hospital partners. And then a big issue for us is we have hospice everywhere we are at. We have no palliative care, no effective palliative care. And we have a lot of patients who go to the ER because they don't know how to die. So we need to fix that.
I'm just curious, do you have behavioral health providers at your clinic?
Yes, we have integrated behavioral health. They see our patients. Like, for example, there were 17 behavioral health visits. Licensed clinical social workers who had seen that patient, that case presentation.
It looks like the mental health column is one of the out there. So
Yep.
I'm just wondering how heavily you're
Absolutely, yeah. Yeah, and what we do in the clinic is solution-focused, brief intervention, self-management, engagement, cognitive behavioral health therapy. But this patient clearly needs a higher acuity of has a higher acuity of mental health needs and needs to be in the mental health center. And she told us she was going to the mental health center, but she actually wasn't because they closed her case. She didn't even have an open case. Colleen.
Are you able to share your care plans with the students?
We have an ongoing, It's called the C4, so complex. I'm sorry, yeah, the question was, do we share our shared care plans? And we share the shared care plan with mental health. In this case that we presented, we have a complex client committee, collaborative, C4 is what it is. And we bring everybody in together and we have a shared consent form, and we actually take those clients and actually bring them in with all the case managers from the hospitals, the ERs, mental health, everywhere, the jail, ARC, the homeless shelter, and the client comes and we talk about the care plan in this C4 committee. Yes?
When you look at your emergency room visits, are they going to the emergency room because the acuteness of their episode is beyond what you can provide care for in the clinic, or is it that they can't get into the clinic, or is the clinic closed during that time?
Yeah, most of the time, the patients we're looking at, they're patients who call up and say, I have crushing substernal chest pain that radiates to my jaw.
Oh, so you tell them where they
So
are.
this case, no matter where he or she goes, she can get in because they are very schooled in the lingo for getting to the ER. Quite effective at getting.
Available to provide care necessarily, huh?
I don't know. This patient comes a ton.
Yeah, if somebody calls like that would be the first thought would be whether having some kind of heart issue.
Right.
And you'd want them.
Right, and we don't want to bring those people in. So we have advanced access. We try to bring everybody in we can. However, so the question was, what's causing them to go to the ER? And that's what we're hoping to learn. There will be a group of behavioral folks. There will be a group of people who are in strings. I think that's what we're hoping to learn, to be smarter.